Hi everyone, my name is Dr. Netto. I'm one of the junior doctors that works as part of the clinical team on junior emergency medicine. And today I'm going to be delivering a lecture on an ST elevated myocardial infarction, also known as a STEMI. So by the end of the session today, I'd like you to have an understanding of what a myocardial infarction is. Good news is that's just the medical term for a heart attack, which I'm sure lots of you have heard about. I'd also like you to understand the basic process that occurs in a heart attack. I'd also like you to appreciate the symptoms of a heart attack. And finally, I'd like you to know how to diagnose and treat an ST elevated myocardial infarction, which is just the worst type of heart attack that you can have and is shortened to the abbreviation STEMI. Okay, so firstly, what is a myocardial infarction? Well, in medicine, sometimes it's really useful to break down each word because it gives us clues as to what it actually means. So myocardial, myo means muscle and cardial means heart. So we're talking about the heart muscle. And when we look at the word infarction, well, that means death of tissue due to a lack of blood flow. So myocardial is the heart muscle and infarction is death due to a lack of blood flow. So if we put that all together, what a myocardial infarction is a death of the heart muscle tissue due to a lack of blood flow. This is a really basic diagram of the heart itself, and you may have come across a similar thing in your studies. The heart is an organ that sits in the middle of our chest, so just behind our rib cage, and it's slightly tilted to the left-hand side. It's made up of 4 different chambers, the 2 atrium, which sit at the top, and the ventricles, which sit at the bottom. Surrounding those ventricles and that atrium is this layer of muscle that surrounds it. It's that red layer that you can see in this picture on the left. And that's what's called the myocardium, which is the heart muscle. You may know that the heart's muscle is to pump blood around the body, and therefore it's really important that it has a strong myocardium and a strong muscle so that it can contract and pump blood efficiently around the body. Okay, but why do tissues actually need oxygen? Well, tissues in our body all respire, and respiration is most efficient when it's done aerobically. So aerobic, needing oxygen. So any tissue in our body, whether that be a muscle in our leg or an organ in our body, needs blood flow so that it can have oxygen in order to respire. And through respiration, those organs and those tissues can create energy, and that's what's necessary to do their function. So if it's a muscle in the leg, it needs the energy in order to contract. If it's an organ in our body, like our heart, it needs that energy in order to contract and pump blood around our body. But remember, the heart itself is an organ, and therefore it needs its own blood supply, and it has its own blood supply. This is one of the biggest vessels in the body, the aorta, and that's what comes off of the left ventricle in the heart. And as soon as the aorta stems off from the left ventricle, it branches off into all the coronary arteries, which are the names for the vessels that line the heart. So the heart has its own blood vessels in order to have its own oxygen supply. And by having its own oxygen supply, it can go through aerobic respiration, generate energy, and contract. And I'm sure you can imagine that if there are any blockages in any of these arteries, that's going to lead to trouble because we're not going to get delivery of oxygen to our tissues. But how can we get blockages? Well, really, that depends on if we're talking about veins or arteries. Let's think about arteries in particular for today's lecture. And the main way that we can get blockages in our arteries is through a process that is called atherosclerosis. This is a diagram to show you what atherosclerosis is. Here you can see the artery, which should be a nice patent lumen so that blood can flow nicely through it. However, unfortunately, what you've got here are these yellow plaques that have formed within the lumen of the vessel, of the artery. And those plaques are formed due to fatty deposits. So any excess fats that we have in our body, such as cholesterol or other types of fats, they can be deposited in our arteries, and that can build up and lead to atherosclerosis. Now, I'm sure you can see by this diagram, if the atherosclerosis is really severe, then that's going to restrict the blood supply through that vessel, through that artery. And ultimately, what's going to happen is any tissue that's beyond that point is therefore not going to receive any blood supply and not receive enough oxygen. And that's where the trouble is. So if we just go over that process again, if we have a blockage in any of our arteries, that reduces the blood supply to the tissue. In turn, that reduces the oxygen supply to that tissue, and ultimately leads to a myocardial infarction in the case of the heart. And if we just remind ourselves what the term myocardial infarction means, myocardial infarction is death of the heart muscle tissue due to a lack of blood flow. So I hope that that concept makes sense now. If you want to pause here and re-watch these slides, then please feel free to do so. But we're going to move on for today. Right, so let's think about what different factors would predispose somebody to developing atherosclerosis. I'd encourage you to pause the video now and just have a little think about what sort of factors or what in a patient's life may mean that they are of higher risk of developing atherosclerosis. But here I've summarised some of the key points, but there are loads more that you can look up in your own private study, or you can ask us on the JEM day itself. So if we talk about each of these in turn, diet, of course, if we have a really high fatty diet, which is high in those unsaturated and saturated fats, and also high in cholesterol, any excess fats is going to be deposited in our arteries. Equally, if we have a sedentary lifestyle, so we're not exercising, then we're not burning off those fats, and any excess fat is going to again be deposited in our arteries. Diabetes, through a really complex process, changes our vessels in our body, which again leads us to having a higher risk of developing plaques and fatty deposits. That's the same case for smoking, which changes our arteries and changes our veins in our body, and again leads people to be of higher risk of developing atherosclerosis. And the same can be said for high blood pressure. So there's lots of different points that I picked up and I've demonstrated here. Some of them you may have thought about, others you may have not done. But it's just to demonstrate that it's a multifactorial process. Right, so we're moving on to a presentation. How are we going to spot a patient who's having a myocardial infarction or heart attack? I think this picture on the left demonstrates it pretty well, because the main thing that a patient's going to present with is pain. They're going to be in what we call 10 out of 10 severe central crushing pain. So the pain is in the center of their chest. Sometimes it can even be on the left-hand side, and it radiates, which means that it moves. So it can radiate down a patient's left arm, so all the way down their left shoulder into their arm, or even into their jaw. That's the really classic picture of what that chest pain will be. So it's central, it's severe, it's crushing, and it radiates. The next thing to consider is, how do they look? Lots of these patients do not look well. Actually, most of these patients don't look well. They look really pale and they're clammy and they're sweating profusely. And that's because of this really quite severe process that's happening in their body. On top of that, they can feel really sick. So they may feel nauseous and they may even vomit. They can feel really short of breath because of the pain and because of other processes that are happening. And finally, these patients have quite a unique sense, and we call it an impending sense of doom. It's quite interesting to talk to patients who have been through such a life-changing event, and they explain that when they're experiencing this severe central crushing chest pain, they have this overwhelming sense that something really bad is happening to them, and they know that they need to seek help. And they will often offer that up to you, and they'll say, "Doctor, I know that something really bad is happening, but I'm not sure what it is." So that's an interesting one to think about. Right, so we've now spotted that we think our patient is having a heart attack. What are we going to do to assess them? Well, we go back to basics and we do our A to E examination. If we think about that in turn, A is for airway, B is for breathing, C is for circulation, D is for disability, and E is for everything else. So in this case, the airway of this patient is probably going to be fine and it's going to be clear. They're most likely going to be talking to you, and by that you can deduce that the airway is patent. When we think about breathing, we're thinking about the lungs. So they may be breathless and they may even have low oxygen saturations, which you may measure when you put the SATS probe on their finger. And if they do have low saturations, then you're going to give them oxygen. And remember, we're going to give them 15 litres via a non-rebreathe mask. Moving on to circulation, we're now thinking about the heart itself. So obviously this is going to be the one where we're going to find the most abnormalities. And I've listed a few of the things that you may find abnormal here. If we think about the blood tests that you may find, there's one specific one that we do in the cases of a patient who's potentially having a heart attack, and that's something called troponin, which you may or may not have heard of before. What troponin is it's a cardiac enzyme, so a heart enzyme, and it's released when the heart is under stress. So in the case of a heart attack, if you measure the troponin, what you'll find is that patients will have an elevated troponin because the heart is releasing these enzymes because it's in distress. That's one really specific blood test that you can do, troponin. And you may do some other blood tests too, but I'll let you have a think about what you would do. You can even talk to your mentor or one of us on the next day when we see you. Another really important thing to do in your circulation is you want to do an ECG. We talked about an ECG at day 1 of JEM, but remember, an ECG is a trace of the heart. It shows us the electrical activity that's occurring in the heart, which is really important in this scenario, and we're going to talk about on the next slide. Moving on to disability. So there's not a whole lot that you're going to see that's wrong in disability. Remember those 4 parameters. We're looking at the pupils, we're thinking about their GCS, we're thinking about their temperature, and we're thinking about their blood sugars. That's likely to be normal in these patients. But lastly, we're looking into exposure. So we're looking at the patient as a whole, looking at them top to toe in turn, and they're going to look unwell. They will look pale, they will look clammy, and they're definitely going to be in a lot of pain. And at this point, you may want to consider whether you think about giving them something for that pain. So some really strong pain relief, which again, we're going to come on to talking about really shortly. Right, so I mentioned the electrocardiogram or the ECG, which is just the trace of the heart. And we covered this on day 1 when we performed it ourselves. But this is going to be a quick sort of recap, and I'm going to go into a little bit more detail about what the ECG is. You may recognize this wave pattern of the ECG in this picture, this diagram on the left-hand side. And as the heart contracts and goes through the different motions, that's what creates all these different waveforms in the heart. So if I bring up this diagram on the right, you can see that as the heart contracts and then it relaxes, that's what creates these different waves in the ECG that we see. So it contracts, it relaxes, and at different points, that correlates to these different waves that we see. Looking at it into a little bit more detail, if we just concentrate on the left-hand side first of all. So the ECG itself is made up of different waves. Firstly, we have the P wave, which is this first initial bump. We then get the QRS complex, which is this QRS spike. Moving on, we have what's called the ST segment, and then we have the T wave. So again, we have the P wave initially, the QRS complex, which is the spike, and then we have the T wave. And that pattern should simply repeat. So you should have one of these followed by another one, followed by another one, and that would make up your ECG as a whole. Now that's a normal ECG. On the right-hand side, you can see an example of ST elevation, and the name probably gives it away. But if you look at the ST segment in particular, you can see in comparison to the left and the right, the ST segment is elevated, and that's why we call it ST elevation. And if you see ST elevation on a ECG in a patient who's having heart pain or having chest pain, then we can say that this patient is having an ST elevated myocardial infarction, and we can diagnose a STEMI. And remember, I said right at the start, a STEMI is the worst type of heart attack that you can have. There are other types of heart attack, but today we're just focusing on a STEMI. Right, so this is a bit more of a realistic ECG trace that you'll get. I know that there are lots of different lines and that can be a little bit confusing, but remember when you did your ECG, you put those stickers on different parts of the chest. And that's so that when we do the ECG, we can have a look at what the heart is doing from different angles. That's basically corresponds to all these different lines. So all these different lines are the different angles of the heart, so that we can sort of build up this picture of what's happening in a 3D view of the heart. And this is a normal ECG. So if we look at the bottom line, first of all, we can see we've got a P wave, we've got the QRS complex, and then we've got the T wave. And the ST segment looks fairly flat, pretty much in all of these. So we can say that this is a normal ECG. Now, if we move on to an abnormal ECG, you're not going to see the ST changes in every single line because not all the angles of the heart are affected. But if we look here at V1, V2, and V3, we've got our P wave, our QRS, and then our T wave. But look at the ST segment, that's really, really raised. And so if we see this again in a patient who's having chest pain, we can say that this is a STEMI, and we can go on to treat it. Speaking of treatment, for any patient, we can really think about what is the short-term management. So what am I going to do for the patient that's right in front of me, wherever I am, whether that's in a GP practice or in urgent care or in A&E, and then the longer-term management, which is how am I going to deal with the actual problem here. So for the short-term management of a STEMI, or any heart attack actually, there's a nice acronym that we call MONA, M-O-N-A. So the M in MONA stands for morphine. Remember I said that these patients are in a lot of pain, and because of that, we need to give them some really, really good pain relief. So we go in with the strongest pain relief, which is morphine. The downside of morphine, or the side effect, is that it can make you feel really sick. So if you don't give patients an anti-sickness, you may find that they start vomiting. So very often in actual practice, if we give a patient morphine, we give them an anti-sickness medication alongside it. And maybe that's something that you should consider thinking about on your next day of JEM. Next thing is the OS. The O stands for oxygen. Remember we said if the oxygen saturations are low, we're going to give patients oxygen. So you guys already know that one. The N in MONA stands for nitrates. Some of you may have seen that anyone who has chest pain carries around a little spray with them that they spray underneath their tongue, and that relieves the pain. If you haven't seen that before, don't worry. What that is, it's called a GTN spray, and the N in it stands for nitrates. What the nitrate does is when you spray it under your tongue, the nitrate acts on the vessels along the heart and it opens them up slightly, so that if you have an area which has a blockage in it, it will quickly try to open up that vessel a little bit more, which I'm sure you can imagine will hopefully then allow blood to flow through and should, in the short term anyway, overcome that obstruction. And that's why it relieves their pain, because a myocardial infarction, it's the infarction, the death of the tissue, that is really painful. So if you're allowing the blood to now flow through that vessel, you should be able to relieve some of that pain. So that's what a GTN spray is. So you give 2 pumps under the tongue, 2 sprays under the tongue. The A in MONA stands for aspirin. And alongside aspirin, we also give a drug called clopidogrel and also blood thinners. So blood thinners, an example of that would be warfarin. The reason that we give these types of drugs is that we want to try and thin the blood to make it as fluid as possible, so that we're maximising the probability that it's going to be able to get through all of our arteries. And by doing that, it means that we hope that those vessels that maybe are really, really small, if we try to make the blood really liquidy, then we can try to let some of that blood at least flow through those vessels and help that blood flow through those vessels. So that's why we give aspirin, clopidogrel and other blood thinners in a myocardial infarction. Okay, so that's your short-term management. Thinking about our longer-term management, now this isn't going to be in A&E, this is going to be in specialist cardiac centres. And we need to think about how are we going to get our patients from where we are to a specialist cardiac centre, because not all hospitals will have a cardiac centre. For example, in Leicester, there are 3 hospitals and only one, which is the Glenfield Hospital, actually has a cardiac centre. So if anybody's having a heart attack or STEMI in the Royal, for example, the Leicester Royal Infirmary, they need to be blue light transferred. So that means going by ambulance on blue lights all the way to the Glenfield. And a STEMI requires PCI within 2 hours. So we'll talk about PCI in a second, but it requires the definitive management within 2 hours. And that's 2 hours of the onset of the chest pain. So really, you don't have that long in order to get these patients to where they need to be. And in order to get them there as soon as possible, you need to forward plan. So you need to be considering, do I need to call for an ambulance? And you need to be doing that as soon as possible in your management, really. And you need to think, how am I going to get them there? Is it going to be by a taxi? Probably not. You're probably going to decide that it's going to be by a blue light transfer. And lastly, and most importantly, actually, going to alert your senior, because you should not be dealing with these type of things alone. You should have a consultant or a senior registrar around to help you. Right, so I mentioned PCI. PCI stands for percutaneous coronary intervention, which is essentially stenting. What happens in this process is the doctors will find the artery which is blocked. They'll then feed what they call a catheter, but it's basically a really long wire through an artery in our body, and feed it all the way through until they get to the heart, and then feed it all the way into that specific artery that's blocked. So once they're in that specific blocked artery, they then will inflate the balloon. And that balloon inflation means that that stent then inflates and kind of fixes in place. They then can deflate and remove the balloon, and then all that's left in place is the stent. So the balloon is gone, the catheter or the wire is gone, but what's left is this mesh stent. And that's what keeps the vessel open and overcomes that blockage, and that's the long-term solution. Now, a patient may have one of these stents, or they may have several. It really depends on how many vessels are involved and how bad their blockages are. So that's the definitive management of a heart attack and a STEMI. Okay, so that's pretty much everything I wanted to cover for today. If we think about the cycles for JEM itself, so if you were to come across this case on your final day of JEM, just remember your A to E examination, and that will get you really far. Don't forget that your short-term management is MONA, M-O-N-A, and your longer-term management is PCI. You need to be alerting your senior pretty much as soon as you can, and that may be the senior that's around you, or you may even want to call the cardiology registrar, for example, to alert them of what's happening and that you're going to be sending them a patient. And most importantly is you need to get them to the right place. So if you're out in the community, or you're in a GP practice, or you're in the wrong hospital, you need to transfer these patients over to the correct hospital. Okay, thanks for listening today. I've just included a short list of some of the resources that I used to help me make this presentation. And if you have any questions, here are our social media platforms that you can reach us on. Otherwise, save those questions and you can ask one of us or your group leader on the day of JEM. It's great to talk to you guys today, and I'll see you soon.